All right, so this session is mitochondrial disease, what to expect as an adult. And I was given 3 topics to cover, but I think I'll cover the first 2 rather quickly and focus more on the 3rd topic, and I'll show you what these are. Let me just make sure. Uh-oh, yeah, I was told that there was a, oh, here. All right, I'm gonna just start with some background information so everyone's on the same playing field. I think probably all of you know this, that mitochondrial diseases are clinically and genetically heterogeneous, and they're hard to diagnose. Many of you have gone on diagnostic odysseys for months or years to get to your diagnosis of mitochondrial disease. They are rare. That's part of the reason they're difficult to diagnose. But not so rare, 11.5 per 100,000, so probably 70,000 people in the United States or more with these conditions. And among the inherited neurological disorders, they're the most common. And these disorders, as you know, affect virtually every part of the body, but they particularly affect the brain and muscle, which are organs that require lots of energy. And obviously, mitochondria are vital to produce the ATP energy, as we've heard recurrently through this week. And so they're genetically heterogeneous because they can be due to a variety of mutations in the mitochondrial DNA, nuclear DNA, or sometimes even nuclear DNA mutations that cause secondary mitochondrial DNA mutations. And one of the unique features of mitochondria and mitochondrial DNA is that the mitochondrial DNA is exclusively transmitted from mothers to children, and that that DNA is present in hundreds or thousands of copies per cell. And so you can have different levels of mutation in a cell, and from one cell to another, though the level can vary. In general, you need really high levels of mutation to cause disease, usually over 70%. But because these mutations are present in different levels in different people, the same mutation will cause different diseases in a family. So all of these people in the maternal lineage, starting from up here, this grandmother, to her children, to these grandchildren, all have the same mitochondrial DNA mutation, but at different levels. And that's why this here, the one in the dark circle with a line through it, that means the patient passed away, had severe me loss because they had high levels of the mutation. Oops, sorry. And you can see the levels of mutation in muscle and blood, and they vary from patient to patient. But this person who had the most severe problems and passed away in early childhood had 95% mutation in muscle and 85% in blood. And this person here who has no symptoms has a mutation in muscle, but it's undetectable in blood. Okay. And that's shown here schematically showing that different cells have different levels of mutation. So the blood cells have less mutation, muscle have higher levels of mutation. And that's generally true for these mutations. We have the North American Mitochondrial Disease Consortium, which is comprised of 15 active sites across the United States and one in Canada that's investigating mitochondrial diseases on a research basis. We have a registry, so I encourage you to, if you're seeing a physician, a mitochondrial specialist at one of the NAMDAC sites, to sign up for the registry so we can collect information about all of your mitochondrial diseases. And we're learning quite a lot about these mutations. The most common diagnosis among all of these patients is multisystemic disease, meaning there 3 or more organs are affected, but not in a particular pattern, not the classic me loss or MRF or Hirano syndrome. It's something else that we haven't been able to define yet clinically. So it's challenging if you don't have a particular syndrome to call it a mitochondrial disease. So we label them multisystemic syndrome or other clinical syndromes, and many of these patients lack a genetic diagnosis. We do see that there are 2 peaks. There are the young children here in the blue wedge of the circle that have mitochondrial DNA mutations that have mitochondrial disease, and these are generally due to nuclear gene mutations recessive mutations. That means the parents are each carriers, but not affected. But the children who are affected have two mutations, one from the mother and one from the father, and they can be very severely affected in early childhood. And then the other group is what we're here talking about, adults who have mitochondrial disease. And and they could be due to these various nuclear gene mutations shown here in the red. The most common one is Paul gamma. Then in green are the pyruvate dehydrogenase complex deficient patients. And then many of these patients many of these genes are represented by only a single patient. There's only one patient in the registry with that particular gene defect. So these diseases individual diseases can be very rare. And we do see, as I said, that Lee syndrome is more common in young children. So it's different from the adults who tend to have these other diseases like MELAS, chronic progressive external ophthalmoplegia, Leber's hereditary optic neuropathy. And we see that the adult onset patients are more likely, twice as likely to have a mitochondrial DNA mutation than a nuclear gene mutation. So these were the three, well, this is the first of the three subjects, general subjects that I was asked to talk about. And I'm going to cover the first two of these quickly. So mitochondrial disease and age-related conditions. So aging, Parkinson's disease, Alzheimer's disease. Did anyone here request this topic? No? Well, I'll just go through these quickly. It's well known that as we get older, our mitochondria don't function as well. I mean, and some people think that that's the cause of aging. That we get as we get older, we have less energy, our muscles get weaker, our muscles become smaller, sarcopenia, and we develop problems like hearing loss, vision problems. Sometimes that's just shown here, fatty liver, diabetes is more common as we get older. So it may be that the mitochondrial maintenance is not perfect. We're not able to undergo mitophagy, swallow up these damaged mitochondria and get rid of them through this mitophagy pathway. Unfolded protein response. It's a way of getting rid of misfolded proteins. All of this may not work perfectly, and over time we accumulate damage to the mitochondria, which then causes mitochondrial DNA damage, reactive oxygen species, and proteotoxicity. Those abnormally folded proteins accumulate and cause toxicity in mitochondria, which then cause all of these other problems, including oxidative stress and contribute to aging. So we know that if we do a muscle biopsy of normal people who are over, say, 60 years old, we'll see a few ragged red fibers and a few deletions of mitochondrial DNA, and that's normal. So it is part of the aging process to have some damage to mitochondria. And there's even a mouse model. This is a mouse model with a genetic defect in the polymerase gamma. I mentioned one of the most common nuclear gene that's causes of mitochondrial disease. And when in this mouse model, there are some features of aging. And you can see here, this mouse here has developed kyphosis, a bent spine, and has lost weight. And these mice with this polymerase gamma accumulate mitochondrial DNA mutations over time, and in some ways mimic the aging process, and they die or prematurely compared to their normal litter mates. All right, that was the aging in a nutshell. Any questions about aging? Yes, it's a reaction to mitochondrial dysfunction, and typically a reaction to mitochondrial DNA damage or mutation. So deletion mutations of mitochondrial DNA, point mutations of mitochondrial DNA frequently cause those ragged red fibers. Yeah. There are mitochondrial diseases without ragged red fibers. For example, Leber's is one good example. All right. There are a number of connections between mitochondria and Parkinsonism or Parkinson disease. Parkinsonism is a more broad term and includes Parkinson disease, which is the classic sporadic late onset disease. But there are other causes of Parkinson's disease-like conditions, like boxing. Muhammad Ali had Parkinsonism. He didn't have classic Parkinson's disease, but from the damage to the brain from repeated brain trauma, he developed Parkinsonism. So there were some early reports of mitochondrial complex 1 deficiency in Parkinson's disease. And it was detected in blood and platelets, and there was a suspicion that maybe complex 1 deficiency was the cause. Well, it's not really, it's still not clear. This hypothesis got further attention when this neurologist in California, William Langston, identified this group of young people who were developing Parkinsonism. They were young people in their 20s, and they had taken a designer drug called MPTP. And that drug is like Demerol, and they were using it recreationally, but it was converted to this other metabolite called MPP+, which blocked complex 1 and caused Parkinsonism. So that's indirect evidence that maybe complex 1 deficiency causes Parkinsonism. Parkinsonism, certainly, maybe even Parkinson's disease. There are some pesticides, rotenone, paraquat, that are complex 1 inhibitors, and epidemiological studies have linked these pesticides to Parkinson's disease. So there are multiple lines of evidence, indirect, but suggesting that. And then there are these rare genetic forms of Parkinson's disease that are due to mutations in alpha-synuclein, Parkin, PINK1, DJ1. And I won't go through the mechanism, but just say that they're all, the proteins are all associated with mitochondrial functions. So again, implicating mitochondria in the pathway of Parkinson's disease and Parkinsonism. And then that polymerase gamma I told you about being common as a common nuclear gene cause of mitochondrial disease, and that mutator mouse with Pol gamma mutation that mimics aging. We also know that polymerase gamma mutations can cause Parkinsonism. It looks very much like Parkinson's disease. So there are these links. So it's intriguing, but not really proven that there is this link. And in Alzheimer's disease, there are a number of hypotheses about mitochondrial dysfunction. Problem is, we don't know if these mitochondrial abnormalities are truly pathogenic, causing Alzheimer's disease, or if they're bystanders, because it's hard to know. And my colleague, Eric Schoen, has this new idea that perhaps even more specific than mitochondria, that there's this region of the mitochondria that is associated with the endoplasmic reticulum called MAM. And that's where there's a lot of lipid metabolism here, but that's also where the amyloid precursor protein is processed. And he thinks that there are defects in this MAM that are causing Parkinson's disease. There are lots of hypotheses. Bottom line is we don't know. All right, so that's the aging, Parkinson, and Alzheimer's disease story. The second topic I was asked to address is mitochondrial disease and fatigue. So how many of you are with mitochondrial disease, or your family members, are affected by fatigue? Okay, I see the vast majority here. So fatigue is a major component, and for many years it was overlooked, but it is really a huge problem. And we don't know if it's simply due to lack of ATP production and just running out of energy, or if there's something else going on. But it's clearly there. And here, this is a study done by the Newcastle group, in which they used a survey, fatigue inventory score, and they looked at the scores in patients with mitochondrial myopathies here, and patients with controls, and patients with chronic fatigue syndrome or myalgic encephalomyelitis. And you can see that the patients with mitochondrial myopathies have higher levels of fatigue based on this scale. So that's clear. And and then in a sort of related study, the group at Children's Hospital Philadelphia, led by Zoella Kipley Cunningham, did another survey where they asked patients, what are the most common symptoms in your mitochondrial disease, and which of those symptoms would bother you enough to participate in a clinical trial or motivate you to participate in a trial? And the answers were 1, 2, and 3: muscle weakness, chronic fatigue, and exercise intolerance. Would some of you agree with that? Yeah, that's really bothersome. Yeah, I keep hearing stories of people with mitochondrial disease who complain that if they do routine activities, they do laundry, they're wiped out for the rest of the afternoon. They go shopping, and then they're wiped out not only for that day, they're tired the next day and achy. So it's a frequent story I hear from people. And not surprisingly, that these symptoms would motivate people to go into clinical trials. So it's really fortunate now that there are 2 companies that are 3 actually that are targeting primary mitochondrial myopathy as in their trials. So their drugs are targeting that. And one of the things that they're measuring is not only strength, but fatigue. So it's now recognized as an important part of mitochondrial disease. Before we go further, is there anybody want to make any comments or questions about their fatigue? Yeah, I think it's partly, if not all, due to ATP, and we can measure that by different ways, including there's an MR spectroscopy technique where you put a person's leg in a machine and you have them pump up and down on a pedal, and their ATP level is normal in the beginning, but then as they exercise, the ATP level drops, and then you do serial scans and see the ATP level rise again. And it's much slower in patients with mitochondrial disease. So that indicates that probably they're depleting their ATP, and they're not repleting it because they can't make it as fast as a normal healthy person. So that indicates that. There is something you could do, I think, to counteract this. That is exercise. You can do aerobic exercise, and a number of studies done by Tanya Tyvaso, Ron Haller, who are exercise physiologists, have shown that aerobic exercise, such as bicycling or swimming for 30 minutes every other day, can be beneficial in improving exercise capacity, increasing the number of mitochondria, kind of like making ragged red fibers in the muscle by increasing the number of mitochondria. And it can improve your quality of life. However, in practice, I mean, I think that there's a window of opportunity there, because you could do this maybe relatively early or mid phase of a mitochondrial myopathy, but when you're really weak, you can't do 30 minutes of exercise. So maybe 5 minutes of exercise every other day is as a better target initially when you're starting out. You don't want to hurt yourself. And I generally tell people if they're achy for a couple of days afterwards and they're in bed, and obviously they've overdone it. So you have to titrate your exercise when you do that. And another way to look is to check your blood CK. CK is an enzyme that's in the muscle, and when you damage your muscle, it leaks out. So you can measure your CK before and after exercise, and if it goes way up, you've probably overdone it. You've damaged your muscle. Okay. Any questions or comments about fatigue and exercise so far? Yeah, okay. We'll start with here and then we'll go there. So gentlemen, yes.
I know there's been a lot of studies on mental exercise or visualization of exercise.
Yeah.
That it can do not exactly what actual exercise does.
Yeah.
Do it to be beneficial.
Mm-hmm.
Have you heard anything about that as a way to stop the overdoing or the chicken and the egg? I do exercise, I get tired. So
Yeah. Yeah. So I think visualization is a good technique to try. I don't think we've ever studied that. So I think that's something that we'll have to investigate. So at some level. Yeah. Okay. All right. I'll put it on my list of things to do. Okay. All right. But yes, absolutely. The other thing is I would like to mention is that, some of these companies are giving these drugs that enhance mitochondrial biogenesis. So it's exercise in a pill in a way, right? It's just increasing the number of mitochondria. So, and it's probably less painful than exercise. All right, next question, yes. And there was one more. Mm-hmm. Okay. Mm-hmm. Yeah. Mm. Yeah. Mm-hmm. 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 Yeah, actually, I don't know that we've ever studied it. We do know. Yeah. Yeah. Mm-hmm. Yeah. It does make intuitive sense, I would say. I mean, we do know that fatty liver is pretty common in the mitochondrial disease patients. It's often asymptomatic. You pick it up on ultrasound. It's just often an incidental finding, but sometimes it progresses to cirrhosis, and then it can be really damaging. But it would make sense that if you exercise and burn your calories and burn your fatty acids, then yeah, you might be able to reduce the NASH. Actually, I see Dr. Johan von Hove, who's also a mitochondrial expert and has studied liver. So do you have any comments about exercise and NASH? Yeah. Mm. 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 Yeah. Yeah. Mm. Yeah. Yeah, I agree completely. I think that it can be much more effective than any supplements we give, but especially early on. Okay, there's one more question. Yeah, no? Yes? Or did you raise your hand? No, CK levels? No, it's a routine assay that can be done anywhere. I mean, and you could have it done at LabCorp or Quest. It used to be part of the what we call the SMAC, 20 metabolites that were measured in blood. But then some years ago, it was taken off that panel, so people forget about it. But it can be ordered as a separate test. And as I said, it can be. I'm sorry. I think it's useful to use, yeah, for a couple of reasons. One is it's good to know what your baseline CK is. It's an indicator that there's some muscle damage. Often patients have routine, the liver fat panel, your hepatic function panel you hear about, and they often show elevated AST and ALT, which are liver enzymes. But sometimes those liver enzymes are actually coming from muscle. So I've seen patients who've had elevated AST, ALT, who've had liver biopsies, but they never had a CK measurement. And the liver biopsies come back normal, and the internists and the gastroenterologists are confused, and they come to see me because they're suspected of having mitochondrial disease. And I immediately measure a CK, and I find that the CK is very high. And the AST, ALT are coming from muscle, which is indicated by the elevated AST, ALT, and CK. And the other enzyme you could check is GGT, which is a liver-specific enzyme. And you can confirm that the GGT is normal. But so that's important. And some patients undergo liver biopsies unnecessarily because of that. All right. So, okay. Yeah, so I wanted to focus more on these issues because I think these are things that most of you are going to be confronting, because mitochondrial disease patients are generally more likely to undergo surgical interventions, whether it's biopsies, sometimes tracheostomies, G-tubes, and other surgical procedures. So I think you need to be, well, prepared for this. And again, please stop me at any point, because this is, I think these are important issues for you. And there's very little evidence regarding the safest and most effective anesthetic regimens. And because of this heterogeneity that I mentioned before in mitochondrial disease, it's not possible to give uniform guidelines that apply to every single patient. Every patient has to be titrated to some extent. Okay, sorry. Okay, and in general, most mitochondrial patients tolerate anesthesia well. And there's little evidence, of, as I mentioned, about what is the best and safest. But there are risk factors, let's say, for complications. And these depend on the involvement of certain organs like the heart, the lungs, or respiratory muscles more specifically, and elevated lactic acid. So if you have these abnormalities, you're more likely to run into complications. In general, we tell people to avoid fasting or minimize it, and to, obviously you have to be fasted during surgery because you're going to be, if you get general anesthesia, you're going to get intubated. There's risk of vomiting, aspiration. So they try to minimize that by having people stop eating the night before. But you can minimize the problems of fasting by starting IV fluids and giving dextrose intravenously. And this is a good source for information about surgery and anesthesia technique, complications and recommendations from the Newcastle mitochondrial website. Okay, and actually a lot of this information comes from them. So, okay. So see some of these specific factors that are important in stratifying patients for surgical risks are, as I mentioned, heart, muscle problems, including respiratory and bulbar muscles, seizures, gastrointestinal dysmotility, and lactic acid elevation. So cardiac conditions. So heart is frequently affected in mitochondrial disease. I said there are brain and muscle diseases, and heart is another muscle. So cardiomyopathy, that's pretty common. Any of you have heart involvement? Okay, a few of you. And it could be heart, it can be enlarged, hypertrophic cardiomyopathy, they can be dilated. There are a few other abnormalities of heart that can occur. Or you could have abnormalities of the electrical system of the heart, cardiac conduction abnormalities like cardiac conduction block. The electrical system may have a block in it, and that's very common in Kearns-Sayre syndrome. Or this pre-excitation syndrome, Wolff-Parkinson-White syndrome, which may predispose to tachycardia. Whereas the heart block could predispose to slowing the heart, bradycardia. So it's important to see a cardiologist and also the mitochondrial specialist, both as part of your routine evaluation, but especially before surgery. And you often the surgeon and anesthesiologist will ask for cardiac and mitochondrial clearance because of the heart issues. At the very least, you need a routine electrocardiogram and maybe an echocardiogram prior to the surgery. Okay, and if there is a problem with the heart and there's cardiomyopathy, you have to be very careful with the fluid. How much fluid? I told you you stop the eating the night before, but then you start an IV when you get to the hospital, and then but you want to make sure you don't fluid overload, and then your heart doesn't pump, and you accumulate fluid in your lungs, and that could be bad. All right. So then myopathy, or maybe we should pause at the cardiac issues and see if there's any questions about the heart. No? In my experience, I think many of the patients with mitochondrial disease develop hypertrophic cardiomyopathy early that can evolve into dilated cardiomyopathy. And in general, hypertrophic cardiomyopathy is not very common, but it's more common among the genetic cardiomyopathies, and especially mitochondrial disease is common. Okay.
So one quick follow-up on that. So she has both.
Okay.
Are those interrelated, or did she just get unlucky that she has two different?
No, they can occur together, and I've seen that in patients with Kearns-Sayre syndrome or MELAS. Sometimes there are conduction abnormalities. It could be either Kearns-Sayre is particularly common to have cardiac conduction blocks, and that could be fatal. So patients often require pacemakers. But then they get the pacemaker, and then later on, they sometimes develop cardiomyopathy. So the two can occur. And similarly, a lot of patients with 3243 mutation, the common MELAS mutation, have this Wolff-Parkinson-White, and then occasionally they'll get cardiomyopathy. And a couple of my patients have had heart transplants. Okay. All right. Let's switch. One more question about the heart. Yeah. Yeah. Yeah.
Well, I seem to have, my son is a GA.
Mm-hmm.
And when it's time for exchange,
Mm-hmm.
it seems so in the last 3 months, for exchange. Every single time, they want to put me in the afternoon. for the-
Oh, yeah.
And I keep telling him no.
Mm-hmm.
Because first, people are diabetics.
Mm-hmm.
you know,
Yeah. Yeah.
And like, well, yeah, you have food from midnight on. And I'm like, tell me what 8 hours, what time the appointment is.
Yeah.
It's going on 8 hours before.
Mm-hmm.
I'm running right to the last
Yeah.
minute.
Yeah.
And I get mad at me.
Yeah.
And I'm like, well, it's the first appointment.
Mm-hmm.
And I go around and around and around. It's very frustrating.
Mm-hmm.
I don't know how to get them to listen.
Well, yes, you tell them that you really want this procedure done early in the morning. I think that's a great suggestion. Great that all of you should try to get your surgical procedure or any procedure done early in the day. Not only because clearly it reduces the amount of time that you're fasting, but also the person who's doing the procedure is probably more alert. At the end of the day, they're more tired. But yes, I think it's important to try to do it early. And if they don't listen to you, you can have your physician advocate for that.
The anesthesia also, the anesthesiologist is also a problem when he wants to get protocol.
Mm.
Like, no.
Yeah.
And they
Okay.
go, why? And I said,
Mm.
toxic.
Yeah.
And, well, that's how we do that.
Yeah.
But
All right.
then we didn't.
Yeah. We try to avoid propofol, or but I think if you give it for a very short period, it's okay. So yeah, it's often used as an induction for a very short period before, and then they transition to something that's longer acting. But
Not in my study.
oh, okay.
They did protocol out for 10 hours.
Oh, okay. So yeah, so in that situation, you tell him that he has had an adverse reaction to propofol, and then make it clear, because that's different from from most people. Okay. All right, myopathy is very common. How many of you have muscle weakness or exercise intolerance? Yeah. Okay. Again, common problem. And patients with mitochondrial disease often have exercise intolerance out of proportion to weakness. And you may look normal and you may have pretty good strength, but you poop out quickly. Okay. And the muscles not only affect the limb muscles, but respiratory muscles. So the diaphragm, intercostal muscles can be weak. And this causes restrictive lung disease. It's what the pulmonologists describe it as. But also bulbar muscles. So we know that chronic progressive external ophthalmoplegia, ptosis are common, but also swallowing muscles, oral pharyngeal muscles can be affected. And that's an important surgical procedure, any procedure, because if you have trouble swallowing, you're at greater risk for aspiration and aspiration pneumonia. So that needs to be considered. And then because you're weak, you may not walk around as much, and you may and immobility increases the risk of blood clots, deep vein thrombosis in the legs. So you have to prophylactically treat for that, prevent that from happening. Okay, so the recommendations are, if there's suspicion of restrictive lung disease, consider pulmonary function tests and consult a pulmonologist. And if you haven't seen a pulmonologist for a while and you're going to surgery or thinking of having surgery, go back and have it checked again, because your respiratory muscles may get weaker, and that needs to be assessed probably before surgery. And then, as I said, the swallowing issues are pretty common, particularly the combination of ophthalmoplegia and dysphagia. A lot of people with CPO have dysphagia. So that increases the risk of aspiration pneumonia. So that's important to know about and be prepared for. And then, of course, as I mentioned, prophylactic therapy, anticoagulation to prevent deep vein thrombosis. All right, these are pretty, often these are done routinely, but it's especially important in mitochondrial patients. All right, seizures are very common as in mitochondrial disease, multiple diseases like Paul gamma, Melas, Murph. So one thing we generally tell people is to avoid valproic acid if possible, particularly in Paul gamma, because that can precipitate hepatopathy, especially in the young kids with Alport syndrome. It can cause a really severe fulminant hepatopathy to be fatal. Our general recommendations for mitochondrial disease patients who have seizures is to continue the anti-epileptic drugs through this perioperative period. But if you're NPO, you're not able to eat or swallow pills after midnight, you may have to get the medication intravenously. And then all of your medications could have interactions with the things that they're going to prescribe during the surgery, so that has to be checked out. If there are interactions between your anti-epileptic drug and your anesthetic. All right, and then if a seizure develops at any time, preoperatively, during the operation, or after the operation, it needs to be addressed urgently, obviously. Oops. So any questions or comments about seizures? Well, pretty straightforward, I think. I mean, a lot of these recommendations are just common sense, but important to think about. All right. Gastrointestinal dysmotility, often overlooked in mitochondrial disease. So a lot of patients have problems with diarrhea, constipation, abdominal bloating after eating, early satiety. You eat a little bit of food and you get full very quickly because you don't empty your stomach quickly. Esophageal dysmotility. Sometimes food gets stuck in your throat, and even swallowing difficulties in the oropharynx. They're all part of this gastrointestinal dysmotility spectrum. All right, particularly in Mingi, but in Melas as well. And it may be subclinical, meaning you may not even know it's there. But during surgery, it may be unmasked. All right, and the surgery often worsens. That's why these problems become unmasked during surgery, because it's very common because the anesthetic and being immobilized in bed, the intestinal system doesn't contract as well, and you get a paralytic ileus or nausea, vomiting, gastroparesis. So the motility issues can get worse, and even in normal people, there are some problems with GI motility. So if you know you have gastrointestinal dysmotility problems, good to consult a gastroenterologist to take care of it in general, and consult them before the surgery as well. And we prefer conservative management of gastrointestinal dysmotility rather than any procedures, which can make things sometimes worse. And then frequently nasogastric tubes are inserted during the perioperative periods as a way to feed and give medications. All right. And as I said, if necessary, surgical intervention is sometimes done for GI dysmotility, but we try to avoid that. One patient of mine who had a liver transplant recently, had Mingi, developed GI bleeding, gastric bleeding actually, and it was not controllable. And then they ended up taking out 80% of the stomach to get rid of to halt the bleeding and get rid of the source of the bleeding. So sometimes it is necessary to do. It's very rare, fortunately, and drastic, but sometimes surgical intervention is necessary for these GI problems, but we try to avoid it because you end up with adhesions and other problems after GI surgery. So we don't like to do that. All right. Any questions or comments about GI issues? All right. Lactic acidosis. Yeah, sorry. Mm-hmm.
and I have to do a certain regimen,
Yeah.
things to do.
Mm-hmm.
After a while, one medicine will stop working,
Mm-hmm.
that will also stop working.
Mhm.
So I have to switch to something else,
Yeah.
get things moving.
Mm-hmm. Yeah, this is a very difficult problem to treat. There are a few things that you could do. Laxatives. Sometimes we use polyethylene glycol. We try to start with milder agents like colace to soften the stool to help. One thing that I found useful is to screen for bacterial overgrowth in the intestine. There's a breath test you can take. And if that's present, that could be ameliorated by antibiotics. So that's something that most general physicians won't think about, but if you tell the gastroenterologist, they'll know how to do this breath test and possibly use some antibiotics. Okay. Sorry. All right, lactic acidosis. So that's very common, but not uniformly present in patients with mitochondrial disease. We use it as a diagnostic test, and if it's present, it's helpful. But absence of lactic acidosis doesn't exclude mitochondrial disease. All right, and it's important in this surgery period that to know that lactic acid may be elevated as at baseline. And because surgeons and the ICU teams and the recovery room teams may measure lactate and they think, oh, this is a sign of distress. Maybe this patient has an infection, maybe a sepsis, maybe there's hypoxia, maybe there's a small bowel perforation. And it may be just that's the normal baseline lactic acid. So it's important, as you'll see in the recommendation, to get a baseline lactate measurement before the procedure so you know where you're starting from. And patients with a very high baseline lactate are probably at greater risk of surgical complications just because the body is straining to make energy using anaerobic glycolysis there. And so there's the system is more compromised and more vulnerable. So absolutely important to get a baseline blood lactate prior to surgery, preferably get it from the venous blood or arterial without a tourniquet. And it's not uncommon to see a mild to modest elevation of lactate after surgery, but if it goes way up, then you might need to be concerned. Some people recommend avoiding lactated ringers because that is as an IV solution. But as Mark Tarnopolsky recently pointed out to our group, lactate is actually an anion and may actually buffer the acidosis. But anyway, it may elevate the level of lactate. So in general, I think it's probably a good idea to avoid lactated ringers just because it may confuse the picture here. All right, preoperative consideration. Okay, before the surgery, it's important to consult your mitochondrial disease expert, go over these issues, and other specialists, depending on where your problems lie. If you have heart problems, see a cardiologist, gastroenterologist for GI motility issues, and so on. And often the surgeon or anesthesiologist or both will request letters of medical clearance from your specialist. All right. And then the people who are doing the procedure, involved with the procedure, need to be aware of all of these factors we've gone over that increase the risks of complications or during and after the procedure. So some of the baseline things you need to do before procedure is routine bloods, including, but not, and some not so routine things like venous lactate. CK is good to measure for reasons we discussed before. Calcium, magnesium, hemoglobin A1C, which is a marker of diabetes. EKG, it's often done routinely, but especially important in mitochondrial disease. In patients who are known to have gastrointestinal dysmotility, it's maybe good to get an abdominal X-ray before the procedure to see what the colon and the small intestines look like. If they're dilated at baseline, well, we know that's the baseline. And then after the procedure, if they do an abdominal X-ray and they see that the intestines are dilated, they'll say, oh, well, it was present at baseline. It's normal because dilated intestines can be a sign of ileus but if it's present at baseline, it's not something new caused by the surgery or the anesthesia. So having a baseline EKG and abdominal X-ray can be very helpful in interpreting these studies after the operations. All right. Anesthesia consideration, there's no, as I said, no good evidence regarding the safety and efficacy of routinely used anesthetics. In general, as I said, anesthesias are generally well tolerated. And as I said, propofol is generally considered safe. There are some exceptions for just the induction of anesthesia, but prolonged propofol should be avoided, absolutely. So because propofol is toxic to complex 1 of the mitochondria, it can really cause damage. And unfortunately, we've seen cases of children who had Lee syndrome and had propofol anesthesia, and they developed brain lesions because, well, probably related to the surgery and possibly related to the propofol. This question often comes up: is there increased risk of rhabdomyolysis, muscle breakdown, due to mitochondrial disease or malignant hyperthermia? And to our knowledge, in general, no. Right? There may be a few cases, but generally, no. Johan, have you seen? Yeah. Yeah. I have not seen any cases of rhabdomyolysis or malignant hyperthermia. There are other genetic myopathies where that may happen, like ryanodine receptor mutations that are known to cause malignant hyperthermia, but not in the case of mitochondrial diseases. Okay, and then we discussed this before. It's important to stay well hydrated during the perioperative procedure. But if you have bad heart and you have congestive heart failure, you don't want to overdo that. So you're walking a tightrope there. All right. Any questions about these anesthesia issues? All right, and then after the surgery, the recovery may be delayed. Your cognitive, you may be slow in waking up. Motor functions, may be weak. Respiratory functions may be compromised after you don't breathe as well. But it's important to try to take deep breaths, and they give you that device that you inhale, incentive spirometer. It's important to do that to fill up your lungs and avoid atelectasis, which collapse of your lung, and which could predispose you to pneumonia. So, but be aware your recovery may be delayed. And make sure you stay hydrated and take adequate calories because fasting or dehydration can be harmful for people with mitochondrial disease. Hyponatremia is sometimes seen in patients with particularly MELAS or the M3243 mutation. It seems to be more prone to hyponatremia, low sodium in the blood. And then the IV fluids can be adjusted to give you normal saline or even hypertonic saline if necessary. And then we talked about this before, deep vein thrombosis prophylaxis, giving Lovenox or other anticoagulation to prevent clots in the legs. All right, and then other postoperative issues. Diabetes has to be managed because diabetes is common in mitochondrial disease. So in the same way as other forms of diabetes, except that you should avoid metformin if possible. Urine output should be monitored. Again, absent or reduced urine output should be rapidly assessed. For other causes, that could be renal kidney damage, and you need to know about that early so you could intervene quickly. Bowel care, we talked about the dysmotility issues, and there are particular diseases like Mingi or MELAS or the 3243 mutation that tend to have more GI dysmotility problems. So it's important to identify the constipation early and initiate this bowel regimen to try to normalize the bowel movements. And then, preoperative bowel care is important. And then often patients get opiates, morphine or other drugs to reduce the pain from the surgery, but that will cause constipation. So you want to minimize the use of opiates if possible. And then, as we talked about, sometimes if there's ileus or suspicion of ileus, abdominal x-rays are done. But again, it's important to have that baseline study before the surgery so you have something to compare with.